As you can see, the topic of my presentation is management of asthma COPD overlap syndrome. This is, at least to me, a fairly difficult talk because you know that in the recent few years a lot of different opinions have been produced about this situation. But because this situation to have in the same patients some aspect of asthma, some aspect of COPD is fairly frequent in clinical practice, I think that correctly Gold and Gina are producing a document where they try to define, to manage, also to give some indication for management of this situation. This chapter number 7, is part of the new GINA document which will be published in next May, and is totally dedicated to this situation. And you can see there is the definition of asthma, the definition of COPD, and the definition also of asthma COPD overlap syndrome, which is defined in a very broadly way, so in a pragmatic way. As you can see, is characterized by persistent T4 limitation with several features usually associated with asthma and several features which are associated with COPD. So there is no specific indication what means that. But I try to explain this point. In effect, this situation is fairly frequent, and these are the epidemiological data produced by our epidemiologist in Italy, and the prevalence of self-reported physician-diagnosed asthma and COPD is different in the different group according to age, but the white column, which refers to asthma plus COPD, as you can see, is present particularly in the oldest group of patients. And also other data, like this one, reported a high prevalence of a mixture of asthma and COPD feature in the total population with airway obstruction, particularly in the oldest group of patients. In effect, we are used to teach to our students, to our fellows, that asthma is asthma and COPD is COPD. So there are two different diseases defined by risk factors, different pattern of inflammation, and different functional aspects in terms of fully reversible obstruction in asthma and not reversible obstruction in COPD. But obviously, between these two terminal final positions, there is a lot of intermediate situation. I try to summarize which are the main characteristics of asthma and COPD. Obviously, between risk factors, atopy is relevant for asthma. Clinical manifestations are related to a complex of different symptoms. The main characteristic of them are variability over time and induced by specific triggers. Functional manifestation may show that pulmonary function may be normal after treatment in some patients, but in any case there is a large variability in FEV1 over time. And in several patients, the biologic pattern is related to eosinophilic inflammation, and usually the response to treatment, particularly to ICS, is good. This is the new definition of asthma. This is just a draft. Probably in the final version some changes can be done. But in effect, you can see that asthma is defined as a clinical syndrome, or more easily an heterogeneous disease, characterized usually by airway inflammation with a lot of other data related to symptoms, to the variability. But considering this heterogeneous aspect of disease, there is a great focus on the primary role of lung function variability in diagnosis of disease. And between all the tests that you know very well to demonstrate the variability or reversibility of reobstruction, particularly the variation behind the normal range when lung function is repeated over time on separate visit is one of the best points. So I personally believe that considering that asthma is really a heterogeneous disease because symptoms are not specific, may be blunted by bronchodilator treatment or by poor perception by the patients. The risk factors are different and various. The mechanism is not always typical like eosinophilic inflammation as we know. So I think that the main point for assessment of asthma is really demonstrate the wide variability over time of a pulmonary function. That I personally believe is the main characteristics of asthma. But you know that, as we mentioned before, asthma is a heterogeneous disease. You know that there is some discordance between inflammation and symptoms, and we may have patients with a high level of inflammation but low symptoms, low level of symptoms, and on the other hand, more frequently, patients who have a low level of inflammation, particularly a different kind of inflammation, and instead a lot of symptoms, a lot of functional abnormalities. And this pattern of non-eosinophilic inflammation in mild to moderate asthmatics is a reality because we and other authors obviously before have demonstrated that this pattern of non-eosinophilic asthma is persistent over time without any treatment with the ICS. Although there are some patients, few patients, that may change during the observation in a different pattern of airway inflammation. And we consider the several comorbidities which may be associated to asthma, particularly chronic sinusitis, obesity and related disease, and smoking habit. They are usually associated with a different pattern in front of the classic pattern of asthma that we know very well. And so this draft, this document, the Gold GINA document report, which are the main characteristics of asthma as usually we consider in front of the usual characteristics of COPD, which may be considered the characteristics of the overlap syndrome. Personally, I believe that assessment of asthma to differentiate the disease from COPD may be related to some specific point. One, obviously, when possible, if there is a complete reversion of airway obstruction, post-proteinolysis or after treatment. Important point is to have a normal diffusing capacity. Chest imaging is not particularly relevant for asthma, but it can exclude the presence of emphysema in CT. Moving to COPD, which in my opinion are the main characteristic of COPD. Obviously different risk factors, smoke, clinical manifestations which are different, dyspnea on exercise, chronic cough sputum, we have already seen from previous presentations. Different functional manifestations, in particularly the non-complete reversibility of airway obstruction. The background of inflammation is frequently different with a prominent neutrophilic inflammation, and the response to treatment, particularly to ICS, is a little bit less relevant, consistently less relevant than in asthma. These data are, you know very well, reported, also summarized in the definition of COPD, but you know that we have a consistent percent of patients defined as COPD who never smoked, and this has been reported in different examples. You know also that consistent part of COPD patients may have a very large reversibility, acute reversibility of airway obstruction. You know the baseline data of the uplift studies where you can see more than or almost 50% of these patients defined as COPD, and including the trial of COPD, they had a significant positive response to the bronchodilator test. Bronchodilator was, in this case, used a very large dose of bronchodilator. But in effect, you may see that also there is some part of them who may show a very important reversibility. And also, the presence of bronchial hyperresponsiveness is not limited to asthma, because several studies, few years ago, now I don't think that is a more important point, but several years ago demonstrated that bronchial hyperresponsiveness may be present in large subgroup of COPD patients. Then we have a clinical approach to the definition of COPD with different aspects that you can see in the figure. But obviously, they represent the majority of COPD patients, but not all the patients that we can see. But personally, I think that definition assessment of COPD should be better performed, including measurement of hyperinflation, which is present in emphysema. In asthma, may be observed just during acute attack or if chronic severe asthmatics. Diffusing capacity is particularly relevant because it usually reduces in COPD, particularly in patients with emphysema. And obviously, chest imaging may be important because chest X-ray, in effect, is a low sensitivity in mild COPD patients, but CT, as you have seen before, is very, very representative, very useful for defining the level of emphysema. I would like to show you this data that the group of Pisa, Professor Giuntini, published some years ago, several years ago, showing the very nice correlation between diffusing capacity and the amount of emphysema is assessed by CT, showing the importance of this measurement to assess the emphysema component in patients with complex disease. So if we have from one side asthma with typical feature, this typical feature may change with age, with adult onset asthma, with smoke, with the appearance of not fully reversible airway obstruction, moving towards COPD. And on the other hand, COPD may have some aspect of asthma, in particular related to the presence of a consistent reversibility or the presence of a non-typical airway inflammation or of an inflammation more typical of asthma. And so the overlap syndrome, I think, that should be considered this part very rarely at the medium position between the classic asthma and the classic COPD. This is important to consider because these patients are usually excluded from clinical trials. There is some uncertainty about the diagnosis, but they may represent a good model for identifying mechanistic pathway leading to development of COPD. So if we consider the classic non-proportional Venn diagram, which include COPD in patients with chronic bronchitis or emphysema and airway obstruction, there is a group of patients like that who may have also some features of asthma. This probably represents the definition of this situation. I think that we can discuss different possibilities to define this situation. One is asthma with fixed airway obstruction. You know that in some patients there is a progressive decline in pulmonary function leading to a no longer completely reversible airway obstruction. You can discuss if they represent asthmatic patients or they are COPD patients. I think personally that we need to consider this a specific phenotype of asthma because, as mentioned before, you know obviously there is a progressive decline in pulmonary function in asthmatic patients, particularly asthmatics who started to smoke. But we know from the paper from Leonardo group that comparing patients with the same level of airway obstruction but with different history of COPD, history of asthma, there is a consistent difference also at that point in the level, the kind of airway inflammation demonstrated by the presence of eosinophils in patients with an history of asthma and the presence of an increased level of exhaled nitric oxide. And we repeated some experience trying to differentiate patients with chronic bronchitis from emphysema in terms of biomarkers collected by induced sputum, but we can demonstrate the same thing. So patients with persistent airway obstruction, but with history of asthma, they have a different pattern of inflammation with the increased number of eosinophils and ECP levels in the sputum, and on the other hand, a lower level of neutrophils and neutrophil elastase in the sputum. So I personally think that this kind of patients should be considered asthmatics, a specific phenotype of asthmatic patients. On the other hand, we have COPD patients with a large variability of airway obstruction and may have an eosinophilic component. And we know that this characteristic is a good predictor of response to ICS. And this should be considered also a different phenotype of COPD. That's a point of question. You know that some authors, the group of Leicester, reported data like that, where you can see the level of sputum eosinophilia is a little bit similar between COPD patients and asthma patients. Probably it's not the reality, but in general, we can see in fairly large proportion of patients with COPD, also in stable condition, the presence of eosinophilia in sputum. And you know that eosinophilic inflammation, which is frequent in several COPD patients and mainly during acute exacerbation, particularly mild and moderate exacerbations, we know that this marker is a positive marker of a response to ICS in terms of increase in FEV1 or prevention of exacerbation, and there is also some paper like that where patients who withdrew ICS showed a greater number of recurrence of exacerbation when they started at the beginning with the presence of sputum eosinophilia. And you know also that some authors tried to treat patients, COPD patients, according to the level of sputum eosinophilia, showing a better response in terms of prevention of exacerbation when they were able to reduce consistently the level of sputum eosinophilia. The third situation is the presence really of history of asthma and the presence of smoking habit. So people who reported an history of asthma during the childhood or during adolescence, and they are observed in the old age with symptoms suggestive of COPD. They usually had a smoking history, and they have some abnormalities suggestive of both asthma and COPD. And you know that this group of patients has a prognosis a little bit poorer than other patients, as reported in this data coming from the COPD gene investigators. And therefore, the ACOS is included different aspects in combining data from features of asthma and features of COPD. But in terms more simple way, a proposal that comes from this document is to have, as you can see, a systematic diagnosis, in syndromic diagnosis in adults. So very simple way, very practical way to check using only symptoms and history of the patients, spirometry and chest X-ray, where the patient may be included in asthma, in COPD, or in both situations. And you can see that indication to check these different points related to the age of symptoms, the presence, the kind, the characteristic of the symptoms, the kind of functional abnormalities and the chest X-ray aspects in order to try if the patient is predominantly situated in the column of asthma or in the column of COPD. The suggestion, very easy, is to count exactly the number of sticks that you can have one side to another side and to decide where the patient should be posed. So it's very practical situation. But in effect, the document suggests also to have more specialized investigation. They personally suggest that this should be done. So in terms to examine this patient in terms of diffusing capacity, which is obviously different between asthma and COPD, not regarding awareness responsiveness, but probably also measuring arterial blood gases. Imaging may be particularly useful to differentiate these two categories, and also inflammatory biomarkers, not only in terms of blood eosinophilia or exhaled nitric oxide, but also according to sputum inflammation, or regarding on that, the authors reported that there is no well-established way to check for that. So the point is we need to check different points to have, in my opinion, a fairly appropriate, extensive evaluation of these patients. You know that 2 years ago, the Spanish group produced this document where the authors found fairly good agreement in order to consider which are the measure points to be considered for this definition. And they suggested that the asthma COPD overlap syndrome should be considered when 2 measures of this criteria, or 1 major criteria, 2 minor criteria are satisfied. And they suggest, obviously, that may have some indication for the treatment. They produced also a different distribution of the category of COPD patients, where overlap asthma COPD patients are included in the part of more severe patients, which require a better investigation, a better approach, and they underline the problems of the withdrawal of corticosteroid in this group of patients. As regards treatment of asthma and COPD are obviously different. In asthma, we focus on anti-inflammatory drugs, ICS mainly, and the other drugs, long-acting beta-2 agonists, leukotriene antagonists, are used in addition to, while in COPD, the main treatment is bronchodilators, 1 or more, and ICS or PDE4 inhibitor may be added in specific subgroup of patients. And also the kind of assessment is different. We have more facilities to assess the response to treatment in asthma. It's less difficult, more difficult in COPD, but in any case, we have a different approach to treatment. You know, obviously, guideline for asthma, which recommend to use ICS in all group of patients, apart for very mild patients. And you know also the new suggestion regarding the use of bronchodilators or bronchodilators plus ICS in the different categories of COPD according to GOLD. So the document that will be included in the GINA document report some sentence regarding the problem of treatment in this category. These sentences are not based on any kind of evidence because there is no clinical trial which included this kind of patients. So just an agreement between the people who produced the document. So you can see that treatment will include an ICS in a low or moderate dose depending on the level of symptoms. There is particular attention to consider this point. Be careful to withdraw inhaled corticosteroid in patients where you suspect that there is a component of asthma because they are greater risk to have an acute exacerbation. Obviously, a long-acting bronchodilator must be considered if already prescribed or added. However, it is important that patients should not be treated with a LABA without an ICS. So in so-called LABA, as for asthma. So they are treated mainly as asthmatics of step 3 or more. And another sentence is related to obviously, like COPD patient, because they have a component of COPD, they require an appropriate treatment with a bronchodilators or other kind of treatment they may use. And these other suggestions that you can see repeat the same problem that we have seen. So this is my conclusion. My personal opinion, just my personal opinion, that we need to avoid oversimplification of this diagnosis, because we may make it too simple to be applied a large part of people. Might I think we need an accurate clinical and functional evaluation of these patients. When possible, use TC, CT, and biomarkers. Obviously, we need to treat these patients for the asthma component, ICS, for COPD component, bronchodilator 1 or more, and obviously this patient should be accurately monitored and included in a strict follow-up in order to check really a different outcome if they have. Thank you very much for your attention.
Marina and Giovanni, that's it.
Thank you, Pierluigi, for the nice presentation. I don't want to oversimplify in a sense, but going back to what Dr. Burgel said in his presentation, that the importance of the phenotype at the end of the story is the natural history and the response to treatment. And going back also to the paper that we wrote with Leo in 2003, when we really took people, same age, 60, 65 years old, same airflow obstruction, irreversible, and we look at everything you are describing here, the LCO, imaging, and at the end of the story, the biopsies of asthmatic people were with eosinophil basement membrane thickness, and the other were like COPD. And the only thing that differentiated the two was the clinical history. So those were people that, to the question, did you have asthma in the past? The answer was yes. And the other guys didn't have asthma, but had COPD. So all the reviewers said, oh, of course, it was enough to do anamnesis. So going back to the main point, maybe we are looking the situation in a sense at the end of the story. Maybe the clinical history is telling us a lot. Maybe those were asthmatic at the beginning and then developed this fixed obstruction and vice versa. So maybe it's not a different phenotype. This is what I'm saying.
Yeah, obviously we can discuss if this is a phenotype or not. In fact, is a subgroup of asthmatic patients we may develop a persistent obstruction, while they continue to have the same biological and probably also functional characteristics of asthma. The point is that the more simple way to define this situation is previous history of asthma, smoking habit, persistent, not fully reversible obstruction. But it's not always like that. We may find patients where the reminder of the history of asthma is not clear. There is no demonstration of that. And patients are observed directly at 60, 70, 80 years old. So I think that is more complex than that. I perfectly agree that the example you did and I reported before is not, in my opinion, is not defined as overlapping syndrome. To clarify this point.
Giovanni, last question.
And thank you, Pierluigi, for a very beautiful presentation. I have some terminology problem in my mind, because when I look at this the modern term of overlap syndrome, I cannot avoid to go back to the first document of Snyder with a non-proportional Venn diagram in which asthma was already part of a COPD. Then 10 years ago we published the second report on proportional Venn diagram, and we found in the general population. But then, I mean, what Marina was saying is was always in the debate. So asthma and COPD are different disease. What is changed today that we call overlap syndrome something that, for instance, Ben Barros in the New England Journal of Medicine published as chronic asthmatic bronchitis, showing that they had a different prognosis from the emphysema type and the normal people. So this is something puzzling in my mind.
No, I agree that the problem is not new. We have already data about that. And we know that people from the data from Ben Barros several years ago are patients who have a more stable airway obstruction, but with history of asthma, they had a lower mortality in comparison. Okay, perfect. The problem is to define this group, because some consequence, for instance, is related to treatment. You know that ICS are recommending COPD just in a subgroup of patients, while in this way we may suggest to use ICS also in patients without the limitation that we need to consider for recommending ICS in COPD. So there is some change in terms of approach and management. My opinion that the definition of asthmatic bronchitis, which has been used largely also by us, but mainly by GPs, is not correct. We need to define, I agree that we need to continue to try to have at least as possible the difference between asthma and COPD. Obviously, in some cases there is no possibility, we need to consider this way. But I suggest to have a really accurate assessment of this patient, not based only on just history or just some symptoms.
The bottom line being, never a steroid alone, never long-acting alone. Did I get the message?